Okay, so very good evening, everyone. So, myself, Dr. Rijal Agarwal, orthodontic faculty at AIIMS. So, today we are back with the MDS 360-degree 1 hour power session. Although it's an hour late from the scheduled time due to some faculty emergency, this schedule got delayed. Nevertheless, we are here and I am here to continue from the part where we left back, that is from the cephalometric part, which day before yesterday, there was leftover part. Today we are going to cover it and complete it. So I hope on a Saturday weekend evening, those of you who are able to join very well, because the NEET MDS, the entrance is not, you can say the clock is ticking and the date will be on your doorstep very soon. So once again we'll begin the session. Okay, so good evening once again. So as I said, I'm going to cover and take up the remaining part of the cephalometrics which was left from the last lecture. So before beginning, a quick recap or a quick revision of the cephalometric landmarks, because these are very important before we discuss the further analysis. So as we discussed the cephalometric landmark, there are two types, broadly divided into two types, that is the anatomic landmarks and the derived landmarks. Anatomic are the which representative of the actual anatomic structures of the skull, and derived are those ones which are obtained secondary from the anatomic structures in the cephalogram. Okay, so what are these landmarks? First is the Bolton point. So this is the highest point on the upward curvature of the retrocondylar fossa of the occipital bone, represented by the symbol BO. Porion, so as I told, it is the entrance or the upper contour of the external auditory canal. It is broad of two types, that is anatomic and the machine porion. Machine porion is the representative of the machine ring from the machine lead ring present in the ear rod of the cephalostat. Okay, what we require is the anatomic porion, which is slightly at a different few millimeters away from the machine porions. Generally it is located below it, but sometimes due to head tilt or improper positioning it can be located at the same level or sometimes above it as well. Next, articulate. So it is the intersection of the shadow of the zygomatic arch and the posterior border of the mandibular ramus. Nasion is the anterior point midway between the frontal and nasal bones on the frontonasal suture. Sella is the entrance to the cell cavity of the sella turcica. Orbitale being the lowest point on the inferior margin of the orbit. Basion, the lowest point on the anterior margin of the foramen magnum at the base of the clivus. So this is the articulate, the sella, the nasion and the basion. As I highlighted last time also, point A and point B इनका जो the different name, the other name of point A is subspinal and point B is supramentale. Supramentale being above the mentalis point and subspinal below the anterior nasal spine, hence the name. So point A, the deepest curve point or the innermost point on the contour of the premaxilla between the anterior nasal spine and the incisor tooth. And point B, the deepest point or the innermost point on the contour on the located on the mandible between the incisor tooth and the midline between the alveolar crest of the mandible and the mental process. Anterior nasal spine marks the anteriormost tip of the sharp bony prominence of the maxilla, and the other name of the tip of the ANS is also known as ecanthion. Next, the landmarks on the mandible, that is the pogonion, the anteriormost point, the menton, the inferiormost point, and gnathion, the anterior inferior point located between pogonion and menton. This is a derived landmark formed by the intersection of tangent drawn to this point and intersecting at the lower border of the mandible. Next is the gonion. Gonion, again a derived landmark obtained by drawing the tangent along the lower border and the posterior border of the ramus of the mandible, and the point at which they intersect, the line is extended, gives us the point gonion. So what you need to do is draw a tangent along the posterior border and tangent along the lower border, point at which they extend it, and the point at which they join gives you gonion. Point D is the center of the symphysis. It was given by Steiner. So this is gonion, how you obtain it. Next is condylion, is the most superior point on the head of the condyle. Key ridge, given by Gus Atkinson. It is the lowermost point on the contour of the anterior wall of the infratemporal fossa, located in the zygomatico-maxillary ridge. It corresponds to the roots of the first molar, undergoes least amount of remodeling. Hence, as I said, first molar, maxillary first molar, was considered as the key tooth in Angle's classification system. Broadbent's registration point, it is again a derived landmark drawn from the midpoint of the perpendicular from the center of the cella turcica to the Bolton's plane. So from basion to nasion, and a perpendicular drawn from the cella on this plane gives you Broadbent's registration point. So this is also known as a Bolton plane. Prostheon or supradentale, the lowest and the most anterior point on the alveolar bone in the midline located between the central incisors, and similarly infradentale, located at the CEJ of the lower incisors. Supradentale or prostheon, located on the CEJ of the upper incisors. PTM point or pterygomaxillary point, located at the intersection of the inferior border of the foramen rotundum and the posterior wall of the pterygomaxillary fissure. Posterior nasal point, the intersection of the anterior wall of the pterygopalatine fossa and the floor of the nose. It marks the distal limit of the maxilla. Next are a few soft tissue landmarks, that is the glabella, anterior most point on the forehead, chelion, located at the terminus of the outer corner of the mouth, and subnasal, point at which the lower border of the nose meets the outer contour of the upper lip. So glabella, subnasal, lateral contour chelion, and soft tissue poggonia. As I said last time, anterior cranial base length is from cella to nasion, posterior cranial base from cella to articulate, and total cranial base length TCL is from basion to nasion. De Costa's line represents the outline of the interior surface of anterior cranial base. Camper's line, ANS to the external auditory meatus. Broadbent's line from cella nasion line to anterior cranial base. Huxley line is the nasion-basion line which separates the cranium from the facial skeleton, that is the lower part of the facial bone. And now Ricketts is considered as father of computerized cephalometry, and Riedel gave the SNA, SNB and ANB angle, which we discussed last time during the Steiner's analysis. These are a few vertical planes: upper facial height from nasion to ANS, lower from ANS to menton, total from nasion to menton. Facial planes are nasion pogonion, used in Downs analysis if you remember, and facial axis connects the PTM and nathion, used in Downs analysis. Remember the y-axis or the y-plane. Very important landmark. Remember, I have again taken up these landmarks because in the last IIN exam, direct match the following question came based on the definition of these landmarks. And now the ratio of the upper face to the lower facial height is 45:55. Unilateral and bilateral landmarks already discussed. So beginning and resuming from the part where we left, last time we discussed two big analysis, that is a Downs and Steiner's analysis. The third one is the Tweed's analysis, and as I said, for every analysis there is a reference plane. For Downs it was the FH plane, for Steiner's it was the SN plane, and for Tweed's analysis it is again the sorry for that, it is the FH plane. Okay, so it is comparatively simpler. There are not much values, there are just three values in it: the mandible plane angle, the lower incisor, and the Frankfurt horizontal plane. So this is the Tweed's triangle, or you can say Tweed's diagnostic triangle. Now to understand this, we need to know a bit about the history, or you can say go into the past, how these three angles came and what was the Tweed's philosophy. So remember, if during the discussion of evolution of orthodontic appliances, I mentioned that Angle had two students. He had many, but two became popular. One was Raymond Begg, which we gave the Begg's appliance, and second one was Tweed. Raymond Begg went back to his hometown, that from United States to Australia. There he developed his own philosophy and the Begg appliance. Tweed stayed in the United States and practiced the edgewise philosophy as given by Angle. So what he observed was, over the period of years from 1930s to 1940s, when his cases came back, he observed certain amount of relapse. That is, the occlusion was not stable and all that. The teeth have moved away from their original or intent finished position, which, so going back retrospectively, he analyzed that this relapse was happening because of the improper position of the mandibular incisors over the basal pore. So this was the original cephalogram of taken by Tweed. So he said that because of this improper position of this lower incisor, the teeth are not in harmony with the surrounding soft tissue. So since the teeth are in not harmony with the surrounding soft tissue, and you can more elaborately say that they are not in harmony with the surrounding facial musculature, due to the improper forces exerted on these teeth, there was a tendency of relapse of these teeth. So from there he gave this FMIA, or that is the, also he called it as, very important, the facial harmony angle, or Frankfurt mandibular incisal angle. So according to him, this angle should be 65 degree. So the aim of the orthodontic treatment should be that this angle, what is the FMIA or Frankfurt or facial harmony angle? It is the angle between the Frankfurt plane and the long axis of the incisor. So this angle according to him should be 65 degree. The aim of the orthodontic treatment should be to make it 65 degree. So how to make it 65 degree? You cannot alter the FH plane, you cannot alter the position of the external auditory meatus and the lower orbital. That is fixed. Okay, so what are the other two angles? So the other two angles present in this triangle are the IMPA, that is the incisor mandibular plane angle, and the Frankfurt mandibular angle, FM. Now FMA or FMPA is the according to the growth pattern of the individual. So whether it is downward rotating or upward rotating, orthodontically or through our braces or through our orthodontic treatment, till then you cannot alter it. You cannot alter the growth pattern of the patient. Okay, so again this angle gets fixed, this we want 65 degree. So what you can alter is incisor mandibular plane angle, and by changing this you can alter, because we know from our high school mathematics that the sum of three angles of a triangle is 180 degree. So if you can alter the incisor mandibular plane angle by changing the inclination of the lower incisors. Okay, you can change and manipulate the FMIA according to your wish, because FMPA, FMA is fixed, FMIA you have fixed it to 65 degree, so you can have to alter this IMPA. So from this alteration of this IMPA came the concept of extracting the teeth so as to position the lower incisors favorably over the basal bone so as to achieve optimal facial aesthetics. Okay, so supposedly you want to retract or reduce the IMPA. You need to extract the lower premolar so that the incisors can retract or go inside that space. Similarly, you want to procline the IMPA because the FMA is too less, so IMPA needs to be increased. So accordingly, you have to manipulate it. So what are these conditions? So these are the three case scenarios. So if the FMA is between 16 to 28 degrees, so at 16 degree, what happens? The IMPA should increase, that is should be 95 degree. The FM in all the cases, the FMIA is fixed at 65 degree. So this 65 degree value came after a lot of research by Tweed. He studied a number of all of his cases. He called technically all of his cases and studied, and based on these research and retrospective study, he came up to this value of 65 degree. Okay, so at 22 degree IMPA should be 90, at 28. So as the FMA is increasing, the IMPA needs to be decreased. So, and according to studies, it is seen that 60% of the malocclusion or 60% of the cases reporting in a clinic have FMA between 16 and 28 degree. Now, rest 40% above from 28 to 35 degree, the prognosis becomes fair. Okay, so the IMPA needs to be further reduced, which makes the case towards extraction. And if the FMA is more above 35, that is severe vertical, the prognosis is bad and extraction frequently complicates the problem. How? Because now the patient is towards vertical growth pattern. Their mandible is backwardly rotated, and extracting the teeth to correct the IMPA so that the FMIA becomes 65 degree further deteriorates the aesthetics. So imagine a case, the mandible is back, you have further extracted the teeth, the lower lip also falls back. Hence, he said that the prognosis is bad above FMA above 35 degree. So, as I said, that Tweed stressed the importance of the FMIA angle, recommending it to be placed between 65 to 70 degree, and you need to alter the IMPA or the incisor position accordingly so as to place these lower teeth at an appropriate position. I hope I am clear, because this table and these values are really important for your exam. If anyone has any doubt in understanding this, you can write in the comment section and I'll explain again. The importance of FMIA, its other name as facial harmony angle, and how and when the IMPA or the incisor position needs to be manipulated so that the lower incisors are appropriately positioned over the mandibular, or you can say the basal bone. Okay, thank you. So I'll move ahead. Next comes the relationship between FH and the SN plane, another important value. See students, the SN plane is a plane related to the cranial base, and FH plane is related to the facial bones. I have to Buhadri. Sorry, I did not get you. Utkarsh. Okay, so if there is a doubt, you can write. It's clear, you said. It is clear, sir. I have to. Sorry, I'm not getting the last statement. Okay, anyhow, moving ahead. So, as I was telling, the SN plane is related to the cranial bones and the FH is related to the facial bones. So, there is a certain degree of orientation between these two planes. Okay, so what is the orientation? Normally the SN plane is oriented to at an angle of 6 to 7 degrees and in upward and anterior to the FH plane. Okay, so how the mean value becomes 9.3 degrees with a range of 1.5 to 14 degrees according to the studies, but average value is between 6 to 7 degrees. So if in exam, okay, they ask you about the range, it is between 6 to 7 degrees, and if they ask you the mean value, it is 9.3 degrees. Yes, you have to learn these values, the tweet values. The 65 degree, it's very easy. 65, 25 and 90. Okay, so you have to learn them. Tweet values are relatively easy, and the table. So if the FMA is decreasing by 16 from 25 to 16, accordingly you have to alter the IMPA. The FMI says at 65. Okay, simple mathematics. So how does this orientation becomes important? So imagine a situation, as I told you in the last class only, the natural head position, NHP position. If while positioning the patient in a cephalostat, the patient orients his head upwards, what will happen? The FH plane will also turn upwards, and likewise if the head is tilted downwards, the FH plane will also tilt downward. So what will happen? Because of this tilting up and down, the A and B angle or the position of the nasion will change. So the A and B value, the SNA SNB value, because of the changing in the SN position related to the head, will also change, and subsequently all your cephalometric values will get hampered. So the diagnosis will also change. I'll again explain it to you with the help of this diagram. The rotation of jaws related to the cranial base. So as I said, the jaw basis is if the SN plane, supposedly it inclines like this downwards, what will happen? Relative to the crane, maxillary and the mandible base, these will go back, and supposedly the head is inclined upwards. What will happen? The bases, the maxilla and the mandible base will go forward. So your diagnosis will change. For a same A and B value of same class 1 relation, the A and B value will change, and it can also change in likewise. So what happened? The SN plane has rotated because of the improper position, the bases have gone forward. The SN plane has rotated because of rearward, the bases have gone backward. So what will happen? For the same class 1 case, you can diagnose it as class 2 as well and class 3. और ऑर्थो में अगर आपकी diagnosis ही गलत है, your treatment plan and everything will go wrong. So the most important thing in orthodontics is diagnosing a case properly. Similarly, because of the position of jaws with respect to the cranium, if the jaw bases are retropositioned, that is related to the cranium, the nasion is forward position possible. So what will happen? The A and B value will get decreased, and supposedly both the jaw bases are forwardly positioned, the A and B value will increase. So for again a class 1 case can also be diagnosed as class 2 or class 3, which is an incorrect diagnosis. Hence, this analysis, or this which is not an analysis, it's a Witt's appraisal. So this appraisal came in situations in which A and B reading cannot be relied upon because of the improper anteroposterior relationship of the apical basis, or you can say improper orientation of the SN plane as well. So what does WITS stand for? So WITS is not a name of the person who gave this appraisal. It stands for University of Witwatersrand. It is located in Johannesburg, South Africa. Everything which is in red is very, very important for your exam because it has come n number of times. And who gave this appraisal? It was given by Alexander Jacobson. So as I said, it is not an analysis. There is not many values. It's just intended as a diagnostic aid due to improper position, anteroposterior position of the denture basis, or improper orientation of the SN plane. This I explained. So how it's this appraisal done? So you just need first of all, what you need is an occlusal plane. So as I told you last time, there are two types occlusal plane is drawn. One is a functional occlusal plane, another is a normal. Functional occlusal plane is drawn through the intercuspation of the premolars and the molars. It does not worry about the incisal overbite. So from this functional occlusal plane, perpendiculars are drawn from point A and point B on this occlusal plane, and the distance between them is measured. So AO and BO, A to O occlusal, BO, and the distance between them is measured. So if it's positive, if it's 0, if it's negative, accordingly the diagnosis is done. So average reading is -1 in males, 0 in females. If BO is too much behind AO, that is the lower jaw is too much behind, it's a skeletal class 2. If it's too much ahead, it's class 3. I hope this is clear. Now there are certain drawbacks associated with this appraisal as well. How? Because it is largely dependent on the correct representation of the occlusal plane, and how this occlusal plane can be altered in cases of skeletal asymmetry. So imagine canting of the plane, one side it is down, one side up, so the occlusal plane is disbalanced. As I said, severe cant of the occlusal plane. Remember pitch, roll and yaw. In cases of mixed dentation, or in which the premolars are in stage of eruption or erupting. Next, open bite. As I said, this occlusal plane is functional occlusal plane. It needs to pass through the maximum intercuspation of the molars and premolars. Now bite ही open है, how it will pass. Next, changes due to normal development. The growth pattern is happening, growth is happening. Last, incorrect head position is cephalostat. This occlusal plane, like I said, down and upward, and the head position can be orientated incorrectly like this, transversely as well. So what will happen? You will get two occlusion planes, which will create further problems. So to overcome this drawback, because it's very, very important in orthodontics to diagnose a skeletal class 1, class 2, class 3, because accordingly your treatment plan will vary. There were a number of analyses which came up. A and B was one, which was the first. Next came the Witt's appraisal. Okay, we are going to study one more beta angle as well. So these were developed so that our reliability or our values moved away from the angles of cranial base and relied much more on the position of the jaw basis. Okay, I hope I am clear what was the drawback, why this thing came. If your concepts are clear, you just need to remember the theoretical values. You don't need to mug up the theory behind it. Just remember this as a story. Tweet का क्यों आया, why was this intended. Tweet की values are very easy to remember. You just need to remember 165 degree and rest all things fall into place. Next, Witt's appraisal came, why it came, what was the problem with the A and B angle. It just becomes a story. Okay, next there are 3-4 analysis. You don't need to discuss them all in detail. I'm just going to mention their names. Next is a ligand and burstone analysis. It's a surgical analysis used for orthognathic surgery. COG stand for cephalometry for orthognathic surgery. Second is a pitchfork analysis. It was given by Lyle B. Johnston. It is used to evaluate the amount of skeletal and dental changes after myofunctional therapy. And lastly, it's a third is a quadrilateral analysis. It was given by Rocco de Paul. So there are names of these analysis. Just remember the name, how it's done. If some of you pursue a post graduation in orthodontics, these will become very important, because you would have to do it, I think, every day for your cases. So till now we have discussed anteroposterior analysis. There is one analysis which deals in the vertical planes, that is the Sassoni analysis. So it was the first one to analyze the vertical and horizontal relationships and the interaction between their proportions. Okay, so you don't need worry, there is not much in it. You just need to remember the planes. So it's also a archeal type facial type analysis, and it is based on the convergence of these planes, and proportionality of the face can be appraised. So what are these 4 planes and from point which they pass? So the point is point O. And what are these 4 planes? First is the SN plane. Next is the palatal plane. So palatal plane is the ANS, PNS plane, occlusal plane, and lastly the mandibular plane. So these are the 4 planes which was taken up by Wiggins Sassoni. Okay, and what he said was, in a balanced face, all these planes should pass and intersect through a point which is behind the occipital condyle. So occipital condyle पे कौन सा point है? Point Bolton, BO. Okay, so all these 4 planes should, when they are extended backward, should meet and intersect at a point, that is point O, which is behind the occipital condyle in an ideal face. So when this is not possible, the ideal case is not, scenario is not present in every individual, or can say any individual. So type 1 is the one when the anterior cranial face does not pass through O, 2 when the palatal plane does not pass through O, 3 when the occlusal plane does not pass through O, and 4 is when the mandibular plane does not pass through. So this much only is required at this level. There are number of things in this analysis, but at this level you need to know the 4 planes, the location of point O, okay, and what are the 4 types. Okay, moving ahead, what is Holdaway's ratio? Again, now I'm not discussing all the analysis. Down-Steiner tweets were the one which needs to be discussed thoroughly. Holdaway's ratio is a part of Holdaway's analysis. There were a number of things in those analysis. I'm just taking up one part of that analysis, that is the Holdaway's ratio. It is the ratio of the lower incisor to the chin. So it is used to evaluate the relative prominence of the incisors as compared to the size of the bony chin. So according to Holdaway, the distance between the labial surface of the mandible incisor to the NB line and the distance from the pogonium to NB line should be equal. Okay, so nasion से point B तक एक line draw करी. So the lower incisor tip to this line and the chin to this line should be equal, that is 4 mm. That is, now अगर हम ratio wise लेके चले So they should come as 1:1. If there is a discrepancy, up to 2 mm is acceptable, 3 mm less desirable, and 4 mm more than 4 mm correction is indicated. So how to correct that depends upon discrepancy किस level पे है. If the discrepancy is at the level of incisor, you need to retract or protract as in such. If the discrepancy is at the level of the bony chin, you need to patient need to undergo genioplasty or modification as such. So what he said are more prominent the chin, more prominent the incisor should be, so as to have a balanced lower facial profile. Okay, next comes the Jorg-Zarabek analysis. So again a very important analysis in terms of the position of the mandible with respect to the cranial base. So he had took up 3 angles: the saddle angle, the articular angle, and the gonial angle. So saddle angle is measured from sella nasion to articular. Articular angle is from sella articular to gonion, and gonial angle from articular gonion to menton. So this angle, and this angle. So what is important in this is the inference of these values. So if the saddle angle is more, that is sella, nasion and articular, if this is increased, what will happen? That means the mandible is retroposition with respect to the cranial base. That means agar mandible is retroposition, you cannot advance it forward. With respect to the cranial base, it is posterior position. Whatsoever myofunctional appliance you give, you cannot position the mandible forward in the glenoid fossa. It will just relapse back. So evaluating the saddle angle becomes very important before beginning any kind of myofunctional therapy. Next comes the articular angle. Now this articular angle is between, as I said, sella articular and gonial. If this is large, that means the mandible is retrognathic. Again, the myofunctional appliance therapy is a failure. And lastly, the gonial angle. Gonial angle is very simple. It indicates the growth pattern. If it's vertical growth pattern, the mandible is rotating downward, backward. If you position it forwardly, the myofunctional appliance therapy will fail. So remember these, as I told you, diagnosing a case is very important in orthodontics before beginning because your treatment plan will change accordingly. So please remember the inference of saddle angle. It is very important. Exam में आपको यही they ask you, case based scenario and all that. Next, beta angle, as I said, as the widths A and B angle and widths angle become impervious, you cannot diagnose a case based on this due to inherent problem. A number of angles came up: beta angle, there was a yen angle, okay, W angle. I'm not going to discuss all of them, just one, beta angle. It was given by Dr. Bake and Viridio. Okay, how it's calculated? So from condyle to point B a line is drawn, and point A to point B a line is drawn. So a perpendicular is dropped on this CB line, and the angle between them, this angle, is known as beta angle. So for class 1, this angle should be between 27 to 35 degree, and class 2 it is less than 27, and class 3 it is more than 35 degree. Okay, next, R point or Broadbent's registration point is the midpoint we have already discussed of the perpendicular drop from the center of sella turcica to the Bolton plane. Now Bolton plane is from basion to nasion, not from Bolton to nasion. Just remember that. This point came up in your AIIMS, I think previous AIIMS 2020 or 2019. Broadbent's registration point or point R. So this was the question. The Broadbent's triangle or the Bolton registration point. Next, the cephalometric method for predicting the growth of the mandible was given by. So it was given by Ricketts. Just remember that. Now, last time someone asked me about the E line or the aesthetic line. So I've summarized all of these lines, that is the S, Z, E and H line. A very important thing for your exam, because hardly an exam or alternate time they ask you about these soft tissue lines every time. So what is S line or Steiner's line? Is the drawn from soft tissue pogonion to the midpoint of the S-shaped curve between the subnasal and the nasal tip. Z line, also known as the profile line or Z line, it was given by Merrifield, also known as Merrifield's Z line. So it is drawn from tangent to the soft tissue chin and the most anterior point of either upper or lower lip, whichever is proclined the most. Okay, and it is an angular value, so it intersects the FH plane and the average value is between 75 to 85 degrees. Next, the Ricketts E line or the aesthetic line, it is from tip of nose to the soft tissue chin. And lastly, the H line, it is tangent to chin and the upper lip. So the confusion between Z line and H line. The Z line is from soft tissue chin to the most proclined lip part of the lip, be it upper and lower. And H is from soft tissue chin to the upper lip always, be the lower lip proclined, whichever is. So it is from soft tissue chin to upper lip always. E line, soft tissue chin to tip of nose. S line, soft tissue chin to the bisecting the S-shaped curve. So S line, I've already told you, ideally the lip should touch the line. Okay, whatsoever, if it's ahead, plus value, behind, minus value. Z line, it's an angular value between the Z line and the FH plane, average value between 75 to 85 degree. E line, tip of chin to tip of nose, ideally the upper lip should be minus 4 mm and lower lip should be minus 2 mm. Okay, so H line I have just told you, Z angle I have told you. Okay, there is one more line, that is the B line or Birdstone line. It is from soft tissue subnasal to soft tissue pogonion. So B line आज तक पूछी नहीं गई है. Anytime they can ask you this as well. So S line, E line most commonly asked. H line or harmony line or Holdway line. Z line or profile line already asked. B line आज तक नहीं पूछी गई है, can be asked. So Z angle, as I've told you. So likewise there is FMI angle related to the skeletal bony base. So Z angle is the soft tissue counterpart of that FMI angle or facial harmony angle. So FMIA was 65 degree, Z angle should be between 75 to 85 or 70 to 80 degrees some say. So as the question, the Ricketts aesthetic lane or E line, the lower lip is 2 mm posterior to the plane. The day before yesterday someone asked me this question, so I have cleared it. Just remember, this is 2 slides are very important. जो होता है ना एग्जाम से पहले करके जो जाना ही है एक दिन पहले, उसमें ऑर्थो में ये सॉफ्ट टिश्यू नेज़ल लाइंस जरूर डाल लेना. Okay, next is facial axis and Ricketts analysis. As I have told you, rickets analysis, there are 15-16 parameters. I've just picked up few of them which are important. So like in Downs analysis, there was y-axis or growth axis. Likewise, there is facial axis in rickets analysis. So it is the inferior angle between the nasion-basion plane and the foramen rotundum to nathion. So also used called as the Huxley-Basion plane, as if you remember the horizontal planes which I mentioned in the beginning of my class. So Downs called it as y-axis, Ricketts called it as xy axis. Both दोनों का purpose same है, growth status of the patient. Next are the lip chin throat angle or the cervicomental angle. So it is the angle between the lower lip, chin and the R point, that is along the deepest point along the chin neck contour, and approximately it is 90 degrees average value. Obtuse means anesthetic appearance. Can be in cases of very easy to understand deficiency of chin, low lips are proclined, excess deposition of the soft tissue fat, mandible is retro position or low higher point position. So chin throat angle, likewise there is lip chin throat angle as I mentioned, and the throat length. So average throat length should be 55 mm. Average value being 90 to 110 degree. I hope it's clear. थोड़ी values they are ज़्यादा है, but once the class is over you go through them. I've summarized them or simplified, eliminated most of them, which is most important for exam. I've just taken up that. Another important question. So according to Tweed, inclination of lower incisors by 1 degree increases the arch length by. So students just remember, if they have asked you about question में लिखा है according to Tweed, it is 0.8 mm. अगर ये क्वेश्चन में ये फर्स्ट वर्ड हट जाए according to Tweed, just inclination of lower incisors by 1 degree increases the arch length by, then the answer becomes 0.5 mm. So Tweed only said it is 0.8, rest it is 0.5 mm. So question में according to Tweed word लिखा होना चाहिए, then only 0.8 mm is the correct answer. So that means the question is asking that inclining, whether you procline the lower incisors by 1 degree. So if you procline, the arch length increases by 0.8 mm. If you retrocline or decrease the lower incisor inclination by 1 degree, the arch length decreases by 0.8 or 0.5, whichever the way they have asked you. So Zarabak ratio, vertical analysis में we have done Sassoni analysis. Now there is a Zarabak analysis. It's the ratio between the posterior facial height to the anterior facial height. So posterior is measured from sella to gonion, anterior from nasion to menton into 100. The average value is between 62 to 64%. So decreased value leads to skeletal open bite, and the normal ratio is 45 to 55, very important value. So likewise we have discussed lateral analysis. There are certain posterior anteriors of PA analysis. Just remember the name: Grumman's analysis, Grayson, Hewitt, Cherysky, Ricketts. Ricketts gave both PA as well as lateral analysis. Just remember the name of these scientists. They all gave PA analysis. Lastly, the color coding of lateral cephalogram as recommended by the American Board of Orthodontics. Till date, this is only followed. Very important. So for a pre-treatment lateral cephalogram, it is always traced in black, progress in blue, post-treatment in red, and retention in green. Okay, so this color coding is very, very important for your exam point of view. So that concludes or completes our lateral cephalogram topic. cephalometric analysis. Next time we'll take up model analysis. Okay. I think this time I asked you both about lateral cephalogram analysis. तो it was full of ortho. अगर किसी ने पूरा पेपर है, someone would have seen the paper. Model analysis पर direct question आया था. One question asked you directly calculate, so we'll take up that as well. Okay, so keep studying. अभी थोड़ा शायद there are too much overwhelming हो गया होगा these many values. If you study them with a cool head, बट ईजिली याद हो जाएगी. नहीं होती सो सिंपल फंडा बट आई यूज टू फॉलो. मेरे को वो ओरल रेडियोलॉजी में वो सीवर्ड्स, माइक्रो सीवर्ड्स एंड ऑल वैल्यूज याद नहीं होती थी. सो जस्ट आई रोट देम ऑन अ पीस ऑफ पेपर and stuck that paper in front of my study table where I used to study. So every day when I first study, I just gave a rough reading to that paper. So धीरे धीरे वो अपने आप it came up because it's in front of my eyes every time. Even if I lift up my head from my register and see it, it's in front of me. So automatically it came into it. So likewise you can follow this for these as well. Just a suggestion. Okay. For you. Okay. Anyhow, very full. So got you will do it. Okay. Thank you. If it comes of any help for your exam. Okay. That's why these lectures are scheduled. Okay, so there are many things to be covered. And if anyone has any doubt, very well write in the comment section. I'll be able to answer it. Just do the MCQs and keep studying, keep practicing. So I'll conclude and end the session. Thank you for your time, and if anyone has any doubt, you can very well reach to me. My lectures are always there on Thursdays. Even if not related to that topic, I'll be happy to answer to that. It's not necessary that you have to ask about cephalom, but please about orthodontics only. Okay, so if anyone has any doubt related to orthodontics of any other topic, I'll be very happy to take up that. Okay, not in that, if not possible in that session, I will take up in the next. Okay, but that will be clear. Rest you know where to reach me on the Facebook. We are on the Facebook club, WhatsApp club, Telegram. Today anything, any social media platform, I think we are there. Okay, so thank you for your time. I'll end the session. Good evening.